So we're going to move on now, and I'm going to introduce you to Kate from Calderdale and Huddersfield NHS Foundation Trust, and Sally from West Yorkshire ICB, who are going to present a case study of how they are expanding their inpatient tobacco dependency treatment service to implement a costed type initiative in the emergency department, and this will be in collaboration with the sort of stop scheme as well. So Kate and Sally, thank you for joining us.
Thanks, Alan. Hi everybody, I'm Sally Lee. I work at West Yorkshire Integrated Care Board. I work on tobacco control. So the last 14 months I've been predominantly based on the long-term plan work until recently. We got another person on the ground, and kudos to Rachel Forbes, who's an acting up consultant within our ICB now. And we've really been able to start looking at other ways, innovative ways of looking at tobacco control and being able to make expansions. So I'm just going to share my screen. Everybody see that? Do you see that, Alan? Is it up?
We can, it's up. Thank you.
Thank you. Sorry. Right, lovely. So yes, what we how do I start with this? So I think the best place to start, like I say, is Rachel came on board and we started trying to look at other things that we could do around tobacco control, where we could add value, and really great to kind of hear the voices of the volunteers, because it means we're doing the right thing and we're going in the right direction with that. So just to give you a little bit of background, and I will be glossing over some of these slides because I know we've covered quite a lot already in this presentation, but in terms of West Yorkshire, we have a 252,000 adult smokers. That's 13.1% of the population, which is actually slightly above the national average. It also costs West Yorkshire around £660 million per year. So it is absolutely something that we have to get in control of. We need to start looking at preventative rather than reactive healthcare. So as I alluded to, my baby has been the long-term plan for the last 14 to 15 months. So this involved setting up in-house tobacco dependency services in 6 of our hospital trusts. We've got 13 services in total, 5 acute inpatient, 5 maternity services and 3 mental health services. So as you can see to the left, and the slides will be shown so you can have a look at your leisure, but just some of the fantastic work we've managed to do and achieve over the last 3 years. So it's really good to have a quick look at that. And then some partners of ours, obviously in the bottom right-hand corner. Now we know from the in-house tobacco dependency services that the criteria for this plan is only for patients that have an hospital stay of more than 1 day. It doesn't actually target any other areas within secondary care, such as outpatients, diagnostic testing, emergency department. So for us, it was about thinking, where are we going to add that value? Where do we start? What's going to be effective? And I know a lot of the trusts had also often spoke about expanding into outpatients, being able to offer to partners emergency departments as well. So rationale, again, we all know the harms of smoking, so I'm not going to kind of go into detail around that, but just again to kind of give you some stats around that. You know, we have over 1 million patients seen in our emergency departments across West Yorkshire, and this were between March 23 and February 24, so really, really high numbers. We know that it's going to be cost effective, but it'll have an impact on other services, reducing costs, reducing the need for more interventions of a serious nature. Again, Dominique and Ian have obviously touched on addressing inequalities, but as Dominique said, we can never talk too much about addressing inequalities. And in West Yorkshire ICB, we're always striving to reduce inequalities. So for us, it was a no-brainer to kind of look at the emergency department. The deprivation decile to the left shows that the patients from the most deprived areas are accessing emergency departments. So yes, as Allan said initially, we are rolling out the Swap to Stop scheme, which Allan's kindly been supporting us with that. And what we wanted to do was look at what was in our capability, what was in our funding pot, what was within our resources, and it made absolute sense to incorporate the Swap to Stop scheme because obviously it reduces the cost in terms of treatment. We chose to obviously go with vapes from the COSTED trial, but also we know the effectiveness of vapes, and it's often the most popular, most effective way of treating tobacco dependency. Because we have obviously 6 different hospital trusts, we thought it was only fair to offer this out to everybody and as an expressions of interest. We also supplied trusts with a criteria because although obviously we'd like to be able to roll out to everywhere, we could only, the funding that we had in the pot would only implement in one emergency department. And we needed to know that that hospital were ready to implement and it was feasible for them to implement, such as the ability to supply vapes, as we know that there's still that taboo within secondary care of offering vapes. So I was proud to announce that Calderdale and Huddersfield NHS Foundation Trust were awarded with that contract. And speaking to Kate, we established that we would start with Huddersfield Royal Infirmary, and this was down to the most deprived areas being around that hospital, but also the smoking rates were a lot higher. So, and also you can see there another stat, 1,760,000 patients attend Calderdale and Huddersfield Trust between March 23 and February 24 emergency departments. Again, really, really high numbers. So that really was my kind of whistle-stop tour of where we've got to, and a mere introduction to Kate Frost, who has been doing all the legwork over at Calderdale. And what she's going to do now is just run you through how we're getting on with that implementation. We've just had word from Kate that the vapes have arrived at Huddersfield, so it's all becoming very, very real now. So I'll hand over to Kate.
Thank you, Sally. Hi, my name is Kate. I work at, as Sally said, I work at Calderdale and Huddersfield Foundation Trust. And I have actually implemented the long-term tobacco plan for our adult acute inpatients. At the Trust, we've also got Kate Highway. She's also done the maternity pathways again for smoking cessation with our maternity patients. Kate was recently invited by Ash as well for to the House of Commons to gather support for the tobacco and vapes bill. They've also won an award as well at CHFT, and that's the Trust Award for the hard work and maternity that they've done. So I just wanted to mention that as well, because it just shows that the hard work that we're all putting in within the Trust to support our patients with smoking cessation. I'm very keen, and Sally is aware of this, to provide all patients with a service that benefits not just acute and maternity, but a service across all wards and departments with nicotine therapy to help with withdrawal symptoms and ways of adapting and adding additional layers that are tailored to the patient's needs. As Sally was saying there about the vapes, that is one of the big things that all our patients ask for, and to have something in the Trust now to support that is just it's a game changer, and we know that that's going to be so good for our inpatients as well as everybody else that we're going to be targeting. When having discussions with Sally and Joanna previously, my one-to-ones, because this has been my baby probably since January last year, so this is one of the things I always wanted to do was talk about expansion and look at different areas that we could work on and focus on for smoking cessation, and ED was one of my places that I really wanted to start, because that is the patient's journey, that is where they're starting, and that at the beginning of the journey is to capture patients that actually were not admitting into the bed base. So when COSTED was presented at a conference that I attended to last year, I remember looking at Joanna and smiling and saying, that's so exciting, that is something I want in our ED. So I was thrilled at that prospect. So when we was able to bid, again, very excited, because this is something that we can offer our patients in the emergency department. So the treatment will support their quick journey. We know, again, you've all covered this, but from the disadvantaged communities, they may not otherwise engage. And it's a great opportunity to the engagement, because you're not only assisting their efforts to quit, but also beneficial distraction from A&E waiting times. But again, you know what that's like. If you've ever been in the A&E department, you sat there twiddling your thumbs and the hours go by. So that distraction and support will be amazing for some of our patients, because it will take the mind off other things again, and they will engage at that point.
A couple of minutes warning, Kate.
Yep, that's fine. So to start things going with the service meant having the same values and visions of ICB, and working closer with Sally and Rachel meant that my job was going to be so much easier. They've been great, the support. We've had barriers to discuss, and we've all come together about the data, the recruitment side of things, the funding we had to expedite very quickly to prioritise the implementation quickly. There's also only enough funding for one site. Again, Sally's covered that part and why we chose the HRI site. The internal barriers, again, is just it's recruitment, and it's a challenging to provide the trust as well with a business case to go alongside, and that's something we've also had to consider. Looking at protocols again to allow the vaping, dispensing the vaping products, so we've had that to overcome as well. We're not still allowing vaping on site, if that's one of the questions that some of you are probably going to ask. So again, we'll be discussing that with our patients. We are going to provide a physical vape pack so they can start treatment straight away. And the trust is going to be doing a 7-day service with our new tobacco dependence advisors. So they're going to be doing peak time. So they're going to be doing shift patterns to capture more patients at those areas. So viewing the service as a gateway opportunity to inform patients about alternative services as well, about long stop smoking services, engaging with families beyond this is, just not admitted patients, especially when children are involved in the A&E visits, so we can target the parents and the carers. We're hoping funding will continue with additional funding to expand onto the Calderdale site, and we will be producing a business case to also explore other options for the services. Both Sally and Rachel have organised a swap to stop with a chosen company with eBin, and again, I met them at Manchester, and I was quite happy to have been their chosen company to work alongside. Again, they've just arrived, so massive pallets have just arrived in my office. I've met with the senior leads in ED department, who are also excited to promote value opportunity to our patients from all ethnic backgrounds, and to promote and reduce the health inequalities. With the trust, we've also got the Blossom team, and I've met with Alistair, who runs the service. We've had discussions to see how we can work together, because what they do, they are a support group looking at patients from the age of 11 to 25. And again, it's around abuse and violence. And I know something will get included in the chat about that, but that's going to be really good to also target and focus on them groups of patients as well. So the collaboration is not just ICB. We have been working really closely with the local authority, the stop smoking services, who I must say are absolutely fantastic. We're working and learning from each other, which has been a welcome, from learning from each other's not going so well or what's been going well, and we can all adapt together. I have had discussions with my local authorities to discuss the prospect of jointly working together and expanding with some of their government funding to see how we can work together. And to do that, what my plan would be is to have 2 tobacco dependence advisors, and for outpatients using swap to stop. Subject to further grant funding being received, we are going to be looking at future years and looking at the data and see how that goes. But we are going to look at funding 2 TDS for 12 months and just roll it through the whole of the outpatients departments and see how it goes. Hopefully it will go amazingly, and we will need more TDS ASAP. But again, we didn't want to just target the lung and cancer departments. I want to target everybody, and I want to look at expansion across the site, completely across the whole departments. We've been meeting with different people from the trust, or different colleagues in different areas, because my idea is to have it everywhere, to roll it out to absolutely everybody and give everybody the opportunity to take part in this service, because it's a really good service. My vision is obviously to keep going, and one of my mottos is keep it simple. We'll try it. If it doesn't work, we will change it, we'll adapt it. And being flexible with that service is what's working already for me in the trust. I'm very driven by success, and I really want to push this out as much as possible. But my trust is behind me, and they're really proud of the achievements that we've done so far, and again with maternity. So we are all about prevention and looking at ways what we can all target different areas and different patients from all different areas, and hopefully we can use this swap to stop and really push some of that work. I'm also meeting with occupational health, because we're going to roll it out to our staff members also, again using swap to stop. Again, we spoke to local authority about using some of their vouchers that they've got from the swap to stop scheme, so that again we'll be sharing data and the quit rates will go to them, but that's fine by me. They are brilliant. It's Pretty and Jess, I must say. And they said, but you're doing all the work. Again, it's not about the work for me. It's about the patients and the staff members that we've got. And if we can get those quit rates, I don't mind who gets the quit rates. All I want is to be able to run this service for my trust and reach as many people as possible, including patients and staff and everybody else. So that I've really condensed it, because I'm conscious of the time. So thank you so much.
Kate, Sally, thank you very much. Kate, your enthusiasm and passion for this is now going to spill over to all the other presenters, because I'm asking them to turn their cameras on. So I'm sure we're going to have lots of Q&As, lots of questions for you. So if everybody else is able to turn the cameras on, what we're going to do now is I'm going to hand over to Joanna and Olivia, who are busy looking at all your questions, and they're going to fire them away to us all. Joanna, Olivia.
Thanks, Alan. There's lots of big questions been added in to both the chat and the Q&A. So, and I know I could see that Ian was furiously typing along with other colleagues, answering some of them. Quite a few of them have been around the practicalities of the devices that have been used and chosen to be used. So kind of what device, the amount of pods provided in that. So I thought maybe we can kind of culminate that into a question around what were the thought processes that went behind you choosing the types of devices that you did choose?
Caitlin, do you want to take that?
I can do, yes. It's a really great question, and thank you, because we're actually really proud of the development work that went in to the intervention. Our researchers who are joining us on the webinar today worked really hard with people who smoke to try out a range of different devices. We had a short list of things that were really important to us. We needed to choose a device that was independently manufactured and not connected to tobacco industry funding. And then we spoke to participants about what was important to them. So things like ease of use, satisfaction, availability of the ongoing consumables in the local area. These were kind of aspects that we worked with a panel of people to test. So that enabled us to have a short list of devices and eventually choose the device that we used within the intervention. So that work is actually published, and hopefully more people will be able to post the link to the paper, because it was a very thorough, rigorous process of patient and public involvement that we went through to choose the actual device.
Thanks, Caitlin. Alan?
Yeah, just to add there as well is obviously there's the devices that you've researched and you've chosen, but it's quite interesting, and one of the things we found out when we were setting up the stop scheme is that everywhere is different. So thinking about not only the needs of the clients in an A&E department, but there may be needs of clients in other parts of your treating tobacco dependence pathways as well, and they may need something different products. So just to bear in mind, the stop scheme enables you to have a wide choice of products to choose those. And if you are putting bids in, you can have a mix of different products. So you can have open systems, closed systems. And if you need familiarity with those sort of systems around, there's lots of information from the ASH team who can provide that, and NCSCT team can provide that as well. But there's lots of information around from the vendors who you can talk to about the different types of products that are there. So just so you're aware, if you're putting any bids in the stop, you've got the choice and freedom to actually choose the type of product you need to match to the needs of your clients that are out there as well.
Thanks, Alan. There's also been quite
Okay, I hope that's not. Is it just for me, or is Joe?
I think you've lost Joanna for
lost the sound.
yeah.
Good. Let's take. Oh yeah. Do you want to take over? And any other questions you're noticing, Ian? That
yes, sure. So I think there's the question around the harm reduction, which I think Caitlin was going to talk about.
Thanks. I can't see the actual question. Do you want
I
to
think
just
it
read?
was around yeah, the use of e-cigarettes versus NRT and the vaping cessation as part of the intervention.
I think, yeah, I think
it's
there was some concern about kind of vapes addiction. Yeah, just sort of thinking about the harm reduction side of things there.
Yeah, it's often, I think it's a real a concern of people swapping one addiction for another. But we have to remember that tobacco smoking is an addiction. People become dependent on the nicotine that they inhale as part of the tobacco smoke. But it's not actually the nicotine that's causing them the harm. It's the carcinogens that are inhaled through the combustible smoke. So switching to a vape is a harm reduction option. It enables people to continue using nicotine so that they don't go into painful withdrawal, and that enables them to switch away from the harms of tobacco. Of course, in time, individuals may decide that they want to switch away from using the vape as well. And I agree, we need to develop carefully and research ways of supporting people to do that. One of the concerns with moving away from a vape too quickly is that if people are in nicotine withdrawal, they may be vulnerable to tobacco smoking relapse. And of course, that would be the worst outcome. So I think there's more research that needs to be done in supporting people to move away from vaping if they so wish. It wasn't part of this intervention. We saw continued e-cigarette use in the absence of tobacco smoking as a really positive outcome.
Thank you, Caitlin. I don't know if we've got Joanna or Olivia back.
Yeah, I think she'll be back in a minute, I suspect. So there were another set of questions around smoke-free sites as well, and how whether they were vape-friendly sites. I think that was quite a hot topic as well.
Do you want to take that, Ian?
Yeah, so it is a really important topic. We had a whole range of sites. Some were vape friendly, some weren't. There is a real advantage if people can go outside ED and use the device they've just been given. Obviously, that depends on the geography of the site, but ideally, if they can, and I think there is all important messaging about being. You can't smoke, but you can vape on the site. I think that sends an important message that they are different in terms of harms, as is the evidence. So if you can get sites to move to being vape friendly but non-smoking, that's really useful and facilitates it. Otherwise, obviously, people need to go out of ED and then off-site to then use their e-cigarette.
Yeah, that's really helpful. And there is actually a national network on smoke-free sites that's been set up as well, which is a group of people getting together and supporting each other in making smoke-free, vape-friendly sites happen. So if you want to be put in touch, then get in touch with us and Ash, and we can put you in touch with that network. That's great. We've got 2 minutes left, which is really tight. Anything else, you guys? Anyone wants to say any final parting words? Any of you'd like to say to the participants in the last 2 minutes?
Just to say, I'll put my email in the chat, so if anyone has any remaining questions or want any further detail, please do get in touch. And yeah, we're going to create some more resources. We're going to create a training package, which we'll make freely available. So yeah, we'll be able to share that as well over the next few weeks.
Fantastic. And we will also compile some of the Q&As and send that out in the post-event email as well. So things that, burning questions and sort of themes that we pick up, you will get an answer to those as well. So yeah, that would be good. Excellent. So I think we'll move on to the next section now. So we've got really want to hear from you as well now about how you're going to take things forward and any support that you might need. Ian's already mentioned that the training that's coming up, which sounds fantastic. So I think Claire's we're going to start on a Mentimeter. So again, there should be a link coming up in the chat. Go to menti.com and enter that question. those numbers, and what we're looking for is how soon would you like to implement COSTED in your organisational system. You may never want to, you may want to but not sure, but you might want to do it quite soon, perhaps in the next 6 to 12 months, 12 months, 1 to 2 years, or over 2 years. So yeah, interesting to hear what your intentions are if you're someone who's keen on implementing COSTED in your organisation. Great. So I can see that it's very exciting seeing that there are quite a number of people or organisations looking at implementing it pretty soon, within the next 12 months. That's exciting, which suggests that there's real interest in taking this forward. What we were wondering was whether people would, what support people might want to move this forward. So Ian's obviously mentioned a training, but whether it would be helpful to be put in touch with other people who would also like to be supported, so you can support one another and create a peer group. So if we would be willing to put you in touch with one another, so if you were to type group in the chat and then with your contact details, we would be happy to connect you up as a group. If you'd be happy to lead and facilitate that group, then also put that in. But yeah, do feel free if you would like to be part of that, or again, as I say, if there's any support that you think you would like to support that implementation, then also do put that in the chat. So we'll move to the next one now. I see a few people are keen to be put in the chat. That's in touch, and that's really exciting. So what factors do you think will help enable implementation of COSTED in your setting? What would really help you move forward? So let's hear, this is time for some different responses. So we're getting these up. So so funding is one thing. A business case, resource setup. I suppose the other thing is seeing how lean this can be as well, which is useful, because we know that it's difficult to get funding. Using existing TDAs, training a toolkit to implement. So staff resources. Again, I think that's one of the strengths of this, that there are kind of it's quite lean in terms of what's required. I suppose also just thinking about what you can do with your existing resources as well. A whole system approach, that sounds really important. Getting staff buy-in. Okay, also some concern about environmental impact though, all really interesting. Do keep your questions coming, and then we've just got, I was wondering, Ian and Caitlin, whether you'd be able to say something as well about did you mention something about how much it costs to set this up? As in your presentation.
Yes. So
it's relatively cheap, isn't it?
It is very, so it's really just that obviously if the swap stop covers the equipment, it's then the staffing costs. Which is as much staff availability as you can have, because an important thing to remember is that there will always, between 8 AM and 10 PM, there will always be a person who smokes sat in every A&E waiting room. So actually as much staffing as you can get will help. There's obviously some governance and things like that, but actually if you have an existing pool of tobacco dependency advisors, the move from there to in the ED should be relatively simple if the ED is on board. But yeah, so the cost should be relatively low. It's mainly just that staff cost.
Great. Okay. Well, that's really useful. That's useful to know, and that you kind of want to reduce the barriers as much as possible. It's fantastic to see all the enablers coming through here. Fantastic. So moving on to the next question. What action will you take following this event? So what's in your power? What could you do to move towards your goals? So speaking with management in ED, making an application for swap to stop is a good time to do that. They can be entered any time now. Speak to your smoke-free lead. Linking with local authorities on swap to stop, and doing that joint application. People looking at having a conversation with the ICB and the trust, so thinking about, again, drawing up that system-wide approach, which is really important. Developing engagement with staff and ED. But I think the thing with Ian was that you mentioned, wasn't it, not to that it'd be just emphasising that it wouldn't be an added burden on the ED staff will be a big seller for them, I think, with that. So so fantastic. So lots of actions following on from this. Really, sharing COSTED to MDTs and at a higher board level for support. So some lots of fantastic actions there. So we'll continue to see these coming in, but we'll move to the next question now. Thank you, Claire. We just wanted to ask you kind of how helpful each elements of this event were. So we've still got a little bit of time left, but we've got obviously we had an overview of the COSTED trial, the case studies to see how it was put into practice, the stuff on inequalities, the Q&A time, sharing in the chat, and gathering as a community. So do rank those just so that we get a sense for what you're finding most helpful. And we're getting some really helpful steers in the chat as well about swap to stop. So thank you everyone for those. And I can see that we've got quite a few people who were keen to be in touch with one another to support each other in putting swap to stop, not swap to stop, putting the COSTED intervention into practice in their organisations. So that's really exciting to see. Responses. Whilst that's going on, actually we'll just flip back to the previous one. We'll just look at the various responses for that. People can continue to. Yeah, I've got plenty of those, right? Okay, right. So I think we'll close the polls here now. So thank you very much for all your contributions. You've given lots of food for thought there, and it's exciting to see so many of you moving forward into action. I shall hand back now to Allan.
Thank you, Olivia. And again, I do like the Menti system. It really does help to sort of the straw polls really do help actually, and also makes you answer questions that you know that you want to address. But it's quite good to actually answer them here and now. But what an ideal opportunity in the future to keep coming back with more issues and to share as part of a community on this as well. I want to give some sort of closing remarks really, and say it's been great to hear sort of the evidence base from COSTED today and the opportunities it presents, and to see some of the examples that have been implemented as well, including NHS Trust taking advantage of the swap to stop scheme in order to deliver on this new evidence base around COSTED. And it's important to embed these opportunities to treat tobacco dependence and to promote and make it easy to switch to vapes, particularly across NHS settings. And again, particularly across A&E, with regards to the demographics of those who use A&E, but also overarchingly, as always, to try and tackle those health inequalities as well. If we want to hear more about the implementation of tobacco dependence treatment services in the NHS, and so please do contribute towards the NHS Smokefree network, and make sure you're part of that as well. So network members will receive regular updates and resources and information, plus invitations to interactive events, again, very similar to this. So if you are interested in joining the NHS Smokefree network, please follow the links that will be available in the chats. With that in mind, I've been asked to sort of highlight the next NHS Smokefree network as well on the 25th of April, where Sophia from NCSCT will be talking us all through the training guidance and resources that have been developed to support inpatient tobacco dependency treatment services in acute and mental health settings, and the link to register will also be added in the chat. I want to sort of take sort of a chair's privilege to say it's really great to hear from the COSTED team. Really great to hear that localities are taking this forward with gusto. And one of the things just to flag up is from the key stat that came out that the COSTED trial was how successful it was. And what sort of really resonates with me is that was with a 2-week quick kit. Under this sort of scheme, you can most popular award so far has been for a 4-week quick kit, and actually we're now seeing 12-week quick kits available under the stop scheme. So just think about the opportunity. Would we get better outcomes and better results, better quit rates, where we're actually giving clients not only a 2-week quick kit, but maybe access to a 12-week quick kit as well. Not an opportunity there for them to re-engage with services throughout their quit attempt, to continue to get their additional e-liquids from the service as well. So an opportunity there. So I just want to also say a thank you to all the speakers for their presentations. Thanks to you all for attending today as well, and for joining the event and engaging in the discussion. And a special thank you to the team at ASH for organising this event today and their continued support and leadership, not only for the Smokefree NHS network, but for all the networks they support. As you made aware at the beginning, this meeting has been recorded and will be shared with you all, along with all the slides and the links. And we're trying to answer as many of those questions that are in there as well. And all the resources will be made available today on the ASH website. I think it's time for us to close and say thank you. Any final comments I'm going to ask from Olivia and Joanna? Otherwise, no, otherwise we'll say thank you for today, and it's much appreciated. Olivia, Joanna, thank you for your help.
Thanks for chairing, Alan. Really great to have you with us as part, as you're heading up the Swap to Stop scheme. So yeah, thank you. And have a good day, everyone.
Okay, thank you all.